Hello, and welcome to the webinar. My name is Sarah Knopf, and I will be acting as moderator for today's webinar entitled Joining Forces, Improving Care for Veterans Through HCH-VA Collaborations. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. To the right of the presentation slide, there is a chat box for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 72 hours. Before we get started, I would like to introduce today's presenters. As I said, my name is Sarah Knopf. I will be the first presenter as a research assistant at the National HCH Council. I've worked for just under a year on the Council's research staff, coordinating a study on veterans, contributing to a paper with the Kaiser Commission on Medicaid and the Uninsured, and leading an HCH Quality Leaders case study. Our second presenter is Bethany Gudzinski. Since 2010, Bethany has been the Homeless Services and Medical Operations Manager for Terry Riley Health Services. In this role, she manages the services and coordinates with community partners to garner services for the homeless population in Boise and Nampa, Idaho. In addition, she is leading the patient-centered medical home implementation for Terry Riley Health Services. TRHS is a federally qualified health center with 7 medical, dental, and behavioral health clinics serving 30,000 patients each year in southwest Idaho. Bethany also runs her own business, Trinity Program Design, working with local nonprofits on grant writing, evaluation, and program design. Prior to joining TRHS, Bethany was the Substance Use Disorder Bureau Chief for the state of Idaho. Our final presenter is Brookesanne McKinney. She is the Director of Safety Net Provider Relations and Medical Respite Care at Mission Hospital in Asheville, North Carolina. Brookesanne has 14 years of experience with the homeless population, which began with frontline outreach and case management, and now has evolved into developing and planning new programs like the Medical Respite Project in Asheville. She is a strong proponent of collaboration between healthcare entities to find real solutions to the barriers that consumers face daily by implementing innovative ideas such as SOAR, medical respite, harm reduction, and patient-centered transitions of care. She is the former chair of the Respite Care Providers Network and is active with many projects within the National HCH Council. I would really like to thank Bethany and Brookesanne for contributing their expertise to today's webinar. These are our learning objectives for the presentation. First, attendees will be able to describe a promising practice for initiating a relationship with the local VA medical center. Second, attendees will be able to identify one type of collaboration that can be established between grantees and VA medical centers. And finally, attendees will be able to describe a strategy for linking veteran consumers with VA, supplemental security income, Social Security disability insurance, Medicaid, and other public benefits. Here's an outline of the material we'll cover during today's webinar. First, I'm going to briefly discuss the Council's Veteran Study, including our research questions, methods, and preliminary findings regarding collaborations between HCH grantees and Veterans Administration medical centers. We will then hear 2 perspectives on collaborations with the VA, one from an administrative standpoint and the other from a frontline standpoint. Bethany Gudzinski of Terry Riley Health Services will share her organization's experiences collaborating with the Boise VA, including a formal agreement that links VA medical interns with Terry Riley to staff an internal medicine clinic. Next, Brookesanne McKinney of Mission Health and Hospitals will discuss her experiences working with veterans during 14 years of frontline work. She will share how she successfully built relationships with VA contacts to advocate on behalf of her clients, as well as strategies for linking veteran consumers with VA, SSI, SSDI, Medicaid, and other public benefits. And at the end, we will conclude with a Q&A session. So please submit questions you have at any time in the chat box to the right of the presentation slides. I'd like to note that this webinar coincides with Veterans Day, which was this past Sunday, November 11th. Although increased attention to veterans issues occurs around this national holiday, the National HCH Council is making efforts to bring attention to veteran homelessness on a broader scale through our Veterans Research Initiative. In 2011 alone, over 22,000 veterans received care from HCH grantees. Despite these numbers, a lack of research exists on veterans within the HCH setting. So about a year ago, we began a study to investigate this under-examined issue. We were specifically interested in learning more about the characteristics of the veteran population utilizing HCH services, especially their demographics, health status, unmet needs, and common services received. We were also interested in exploring how HCH projects served veterans, including their identification process for those with veteran status, offering any veteran-specific services, making referrals to the VA, and establishing collaborations with the VA. So to examine these issues, we first conducted key expert interviews and 3 focus groups with HCH clinicians, administrators, and a veteran consumer. Based on these preliminary findings, we developed a comprehensive online needs assessment survey. We distributed this survey in September 2012 to the administrators at all HCH projects. 110 administrators completed the survey, which was a response rate of about 50%. Data analysis is currently underway. This survey spanned many topics, but because this webinar is specific to collaborations between HCH grantees and VA medical centers, I would like to highlight a few findings related to this topic. I think that this data will help set the stage for specific case examples provided later by Bethany and Roxanne. As you can see here, based upon the survey, the majority of grantees had communicated with the VA at some point. 61% of HCH grantees had ever communicated, while 21% were unsure if they had ever communicated, and 18% had never communicated. As you can see, the frequency of this communication with the VA really varied. Among grantees who had ever communicated with the VA, 50% said they did so occasionally, while 22.5% communicated frequently, 17.5% communicated rarely, and 10% communicated very frequently. So it really seemed to vary from site to site. HCH grantees initiated this communication and developed a relationship with the VA in many ways. I want to note that respondents could check all that apply for this question, so contact may have been initiated by several strategies. Most commonly, HCH grantees met VA contacts at a stand-down event and then were able to initiate a relationship from there. 14% made one strong VA contact and built a relationship around that person. 12% began working through physician-to-physician communication. 7% met VA staff through VA administrative outreach. 2% partnered on a grant initiative with the VA, and then 8% initiated a relationship in other ways. So I think these findings suggest that there are really many effective ways to engage with the VA. There's not necessarily one right answer. As you can see here, once grantees established this contact with the VA, their collaborations took many forms. Again, for this question, respondents could check all that apply, so a single grantee could have collaborated in several ways. The most common method was making referrals to the VA with 39%, followed by receiving referrals from the VA, performing joint outreach with the VA, hosting VA outreach workers regularly at their HCH clinics, receiving reimbursement through the VA grant and per diem program, having an interagency agreement with the VA, cross-training, and then co-location of services with the VA. I think it's important to note that 16% of grantees reported no collaboration with the VA. overall, HCH grantees were split about the perceived strength of their relationships with the VA. 37% rated their relationship as strong, while 37% ranked their relationship as weak. So it was very split there. 24% ranked their relationship as very weak, while just 3% ranked their relationship as very strong. I think these findings suggest that relations with the VA really vary significantly from location to location, and that some grantees perhaps have great potential for improving these relations. So, given all that you have just heard regarding communication and collaboration with the VA, I think that the survey question produced one of the most interesting findings. So, despite the fact that 84% of grantees collaborated with the VA in some way, as you can see here, only 10% actually received reimbursement for the services that they provided to veterans. Given the limited financial resources of HCH grantees, these low levels of reimbursement indicate that much progress can be made in pursuing VA and other funding for veteran services. So on that note, we are now going to hear from a grantee that has successfully built a relationship with the VA. Bethany Gudzinski of Terry Riley Health Services is now going to share a great model for collaboration, offering ideas for grantees interested in doing the same. So at this time, I will now hand it over to Bethany.
Thanks, Sarah. Again, this is Bethany Gudzinski. I am the Homeless Services and Medical Operations Manager for Terry Riley. We are an FQHC in Southwest Idaho. And just a little background on who we are and how long we've been doing what we're doing. We have been in existence for 41 years in Southwest Idaho. Currently, we have 7 primary care clinics. 3 would be considered urban for us, not urban for the East Coast, but for us, urban, and 4 very rural, which means a population under about 1,200. Within those, we also have 5 dental offices, and we do co-locate all of our behavioral health services within our clinics, so it's fully integrated. And right now, we look at about 1.64 support staff per each of our clinicians. To give you some background on our demographics and who we see, last year, between 2011 and 2012, just under 28,500 users, so patients, and they typically see us about 3 times a year, so 3 encounters per patient. It's a pretty even mix between males and females, 56% male, 44% female, and 3% of the overall population identified themselves as veterans. One of the interesting things about Terry Riley, unlike some other FQHCs, 65% of our patients are uninsured, and so we fund services not through Medicaid, not through any other funding source, but a lot of patients doing some sliding fee scales and also our HRSA funding. And 64% of our patients right now are below the poverty level. So a little bit about the project that we are currently running as a collaboration with the VA. We started in discussions with the VA about 3 years ago, and that is important because the clinic has been up and running for 6 months. So the one thing that I can give you as a lesson learned is working with the VA is not a sprint. It takes time and it takes a lot of collaborations before things actually happen and get into place, and it's baby steps along the way. But in our case, the VA had been looking for specific opportunities that they actually came to us with. They have a resident program there now, and their residents really needed some community-based education opportunities serving an underserved population, and for us that is who we serve. It's everybody we serve is an underserved population at the Boise Clinic, which is where this project is located. And they also really wanted to help us address the profound healthcare needs within the Valley. There are significant needs for the population that we serve, which is, again, the homeless, chronically homeless, low to very low income folks that have no insurance. And so there really was a philosophical reason that the VA came to us, and not only did they need help with community education for their residents, but also really felt the need to help us with our population. Some of the reasons that we decided to jump into this collaboration, it really does provide us with affordable access to internal medicine for our patients. And because they are uninsured, finding specialty care and internal medicine is hard for our patients and hard for us to refer them to community providers. So that was one of them. It really did help us and is currently helping us raise awareness for future physicians who want to do work in the community. And also our largest funder, which is the Bureau of Primary Health, is really looking for community health centers to expand our partnerships, particularly with the VA. So for us, who is providing our patient care? It's members of the VA residency and the faculty that supervise them. It's staffed by internal medicine physicians, and they are residents that are through the University of Washington as far as our medical students. The services that are provided in this particular clinic, they are provided an internal medicine consult. What happens is the clinicians in any of our 7 clinics can request a referral into the internal medicine clinic and get a consult for their patients. It looks very similar to what we do with our providers in the community. However, because this project is internal to Terry Riley, all of the notes that the residents and the supervising physicians are doing are in our EMR, so there's no need to try and get all of the notes from somebody else. They're already right in our EMR, which is very helpful to us. The patients do remain with their assigned primary care physician and come back to them after the consult, and their primary care physician, along with the residents, follow the patient. And faculty members that are supervising the residents are internal medicine physicians at the VA. So the cost to us, well, the residents and the medical students are not receiving any compensation. This is learning that they have to do as they're moving through their residency. The faculty members really wanted to participate as volunteers and not get paid for this. However, they wouldn't have been covered under our professional liability if they were volunteers. So what we did was they are now employees of Terry Riley, and they make minimum wage. And doing so, the patient fees, which is on a sliding fee basis, so typically our patients are paying about $31 to $50. That actually covers their salary and the limited nursing support. So in the end, to Terry Riley, it really doesn't fiscally cost us anything to have them here and doing this service for us. So getting more down deep into who the patients are now that are being seen in this clinic, as I mentioned, it's been open for 6 months, and 55 of our patients have been seen. Interestingly enough, 6% have been veterans, whereas if you recall, only 3% of our general population are veterans. And there are a couple of reasons that we think that that's the case. Veterans here, as in most of the United States, some of them don't want to be connected to the VA for their own personal reasons. And so this way, they get to kind of be connected to the VA, but really mostly connected with Terry Riley. And so as they come into this clinic, what we have found by doing this is that the patients are much more likely, once they've kind of stepped their toe into working with a VA physician, to actually going then and getting the services that they should and that are available to them for the VA. So it's kind of an unexpected consequence, but a very good one, that our patients are then able to feel much more comfortable accessing the VA. So the patients have many and varied diagnoses. As a FQHC providing health care to uninsured mostly, our patients are complex in general. Many of them have a variety of chronic health conditions, along with behavioral health on top of the medical conditions. So they are seen in the clinic for behavioral health issues, hypertension, pain, diabetes, arthritis, and a whole host of issues that the clinician may just want an extra eye on to take a look at some of our most complex patients. And Terry Riley is a clinic that is overseen by MDs, but we have many more PAs and NPs than we do the oversight of our MDs. And so the PAs and the NPs find this also to be a great collaboration, because their patients can get in to be seen and have additional information given to them as the clinician on their patient. So moving forward, what are we doing? This clinic is very, very popular, and so we are looking at expanding. It's currently run on Tuesday nights from 5:30 to 8 p.m., always full, typically a waiting list. So we are currently in discussions with the VA to increase that time and add another evening. And we're also looking at other subspecialties to add to the clinical mix as far as who they can see and the kind of subspecialties they will look at. So to end the presentation, I want to talk to you about and give you the story of Gary. Gary was our very first patient in the clinic. He had multiple chronic illnesses. He was a homeless veteran. And we saw him, and the VA saw him for about a month, really looking at what was going on with him. And the upshot of what happened to Gary because of this clinic is he is now connected into the VA and the services that he needs. He was chronically homeless. He now has a VASH voucher and is housed. And really his saying and what he says, I think, really goes to what we're looking for in the end from this clinic, which is, I don't think I would have survived without Terry Riley and the night clinic. And in all reality, he might not have survived this winter without what he has now gained through the opening for him through this clinic. So that ends my presentation, and I will now be handing it over to Roxanne McKinney, the Director of Medical Respite and Safety Net Provider Relations with the Mission Health and Hospitals in Asheville, North Carolina. So I will hand it over to Roxanne.
Thanks, Bethany. This is Roxanne McKinney. I'm, like she said, I'm in Asheville now, but I was formerly living in Raleigh, North Carolina as the Director of Medical Respite and a SOAR representative for the Wake County Medical Society. And that's where this comes in with the frontline perspective, just giving a real more social work viewpoint. And over time, myself and the outreach team would see a growing number of vets living in the shelters without health care. And that's really how this collaboration started with the VA and the HCH clinic to make it essential for them to get the health care they needed. And so looking at eligibility issues, there's three top things to look at: discharge status, active duty, and length of service. So a person who served in active military, naval, or air service and who was discharged or released under conditions other than dishonorable may qualify for VA health care benefits. But reservists and National Guard members may also qualify for VA health care benefits if they were called to active duty other than for training only by a federal order and completed the full period for which they were called or ordered to active duty. The minimum requirements were veterans who enlisted after September 7, 1980, or who entered active duty after October 16, 1981, must have served 24 continuous months or the full period for which they were called to active duty in order to be eligible. So this minimum duty requirement may not apply to veterans discharged for hardship, early out, or a disability incurred or aggravated in the line of duty. So this is sort of what we were seeing, is that there was dishonorable discharge. And as being the SOAR representative, I was called to assess the ones in the shelter or at the HCH clinic, and we would realize that they could not get any income. Sometimes they would just get the medical insurance. And so these were ones that really needed some help. So looking at the barriers to VA healthcare on the consumer side, there was just a lot of paranoia, mistrust, and ineligibility. Because of the mental health concerns, a lot of times the paranoia would not want a consumer to even want to step into the office, would either not want to ride the bus, especially if it is a 30-minute ride, but also just mistrust, especially if there was a dishonorable discharge. They just don't trust the VA, and so a lot of times that would trickle down to the doctors, and they would not want to go one-on-one in rooms with doctors that were with the VA. So really it comes down to a choice of service provider, the VA versus the HCH settings, and because of the paranoia and mistrust of the VA, there's difficulty in acquiring the benefits because it is a really dynamic process, and it involves a lot of paperwork. There was transportation barriers to the VA, less financial barriers to the HCH services, and a positive connection with the HCH provider. If there are barriers that are definitely with the paperwork or with obviously getting a ride there, the HCH is closer a lot to the consumers or near the shelters, and so that just made it an easier access to health care. And so I wanted just to give one case study that is complex health, but also just showing the barriers and how we sort of made a care plan for this individual. I'll just call him John. He was walking up and down the halls of the county shelter, definitely schizophrenic, COPD, had a large wound on his nose. And the shelter staff had called me because they were concerned about his mental health. He was talking to himself, very repetitive, and he would forget where the bathroom was, just really lucid. And after having an assessment, I realized that he did have VA benefits, but as he was explaining this, I knew he just had health care. He didn't get any income, and he was too scared to ride the bus line, much less even just go outside the doors of the shelter. So we really had to accommodate this plan to the individual. So what we did was got the doctor from the HCH clinic. He actually came over to the shelter, and he walked with him and sat down with him and built a relationship with him, so that he did trust him. And then after that, he was willing to take mental health meds. And this took a couple months just to get him stabilized. But once we got him stabilized, we got him into a respite bed there so that he had a saved bed. And I did the SOAR application from the beginning so that we started the process of benefits. Once we have him stabilized, then he would go see a surgeon about his nose because he did have cancer. We got his the surgery, and he had treatment. And now looking back at it, he is successfully in a group home, and that's because the benefits came through in about 2 months. He has a whole care management staff, and he has someone that is making sure that he's taken care daily, and now he has stopped smoking. So it was a real success story on just how you can really work together for these individuals. So looking at integrating SOAR into the HCH setting, for those who don't know, SOAR is SSI, SSDI Outreach, Access, and Recovery, and it's an expedited process that SAMHSA have provided that just allows case managers, nurses, whoever that can, to get trained and expedite the process so that these individuals, especially veterans that cannot get income to access quickly to income, and possibly Medicaid if they do not get the medical side of insurance or Medicare. And it really assists with the application process. It's really great to integrate SOAR into the HCH setting because the FNP or doctor on site can flag this individual and call them into the office with them and build a relationship, and just really work together to get the case management and services they need. It's especially important for veterans who are ineligible for benefits, just because that may be the only way that they can get care. Also, just a collaboration with medical respite care. I wanted to add on that just because a lot of times in this setting, if they are unstabilized or are going to have a medical procedure, they may not have a place to go. And if you do have a medical respite care facility in your area, then that's a place that they can heal. And also, if they do have an opportunity for a HUD-VASH voucher, that may be a place that they can rest, and also that the case management for the VA can find them so that you can all work together to get them housing more quickly. Also, just looking at initiating VA relationships, going to the stand-down events, if you could have a table with a SOAR representative, it's just a great way to make sure that the ones that are flagged that do not have income you can meet them on site, and also just building these relationships within the shelter with the VA representative is very important, just so as that staff is going through their patients, they can see if they need to call the SOAR representative to help with the income. But also advocating for the patients at the VA. A lot of times if they are paranoid or just have mistrust with the VA, sometimes just going along with them and just going into the waiting room and filling out the paperwork and just really walking with them is very important so that they maybe can gain that trust again with the VA, but also if they go into the room with the doc and they forget to say some of their symptoms, that you can really be there to advocate. And after you're with them at the VA, a lot of times you can meet the case management, and also if they do have opportunity for other services, you as the advocate can make sure that those are done. And I talked a little bit about this, but with the HUD-VASH referrals, and that's the Housing and Healthcare initiative where you can make sure that if you're a case manager and you know that they can get the referral, just to make sure that you work together to make sure that the checklist of things are done to get the apartment. But also it's just a great relationship, especially if they are in the HCH setting, so you can make sure that medically and everything is on the same page, just to really integrate, so it can really make a successful outcome with the referrals in the VA and the HCH setting. And I'm going to pass the microphone back to to Sarah.
Thank you so much, Brooksann. We are now going to begin our Q&A session. We've got several questions coming in. Please go ahead and submit additional questions if you have any, and we'll try to get to those. The first question, I think, would be to myself. It says, are survey findings available on a state-by-state basis? I'm actually in the process currently of analyzing the survey data, but I would absolutely be happy to share state-by-state data if you are interested. It probably won't be included in the report broken down by state, but if you would contact me, and my contact information is right there on the screen, I'd be happy to get you data for your state. Okay, our next question, I think this could probably go to Bethany and Brooksann, whoever wants to answer. It is, do you collaborate with the VA, such as telehealth?
And this is Bethany, and we don't. We could if we needed to. We are so close that hasn't been an issue or a barrier that we have to address. However, the VA certainly does have capabilities for telehealth, as does Terry Riley. So it's there if we need it, but we have not yet needed it.
And this is Brooksand. No, we never use telehealth.
Okay, great. The next question could also probably go to both presenters. It is, what is a stand-down event?
I could answer that. It's part of the Veterans Affairs efforts to provide services to the veterans. They're usually 1 to 3 day events, and they provide food, shelter, clothing, health screenings, VA and Social Security benefits counseling, and referrals to other services in the community. Usually the county or the VA, they work together to have a big event that is annual.
Great, thank you. And I'd like to note, if you just Google, VA stand down, you could probably find a directory with the local stand down information if you'd like to get involved. Our next question is for Bethany. Bethany, how much staff time does it take to manage your program?
For us, it's pretty integrated, so it's not a lot of staff time. We do have one of our nurses with the faculty in the evening, so we have that. But Terry Riley has a very specific referral process where it goes to the clinician will enter a referral into our EMR. That referral goes to a referral coordinator, and they then set everything up. So it's really integrated into the same system as all the other referrals, so it's not costing us a lot of time on staff, additional staff.
Okay, thank you. The next question is for Brooksand. How do I go about getting a SOAR representative at my clinic?
Well, it depends on your community. I know that in North Carolina, the Coalition to End Homelessness is really the advocacy to train the individuals for SOAR. But in Raleigh, it was actually some grant funding that came down, and so, but eventually you can look at, if you can prove the return of investment at the hospital level or with the LME in your community, a lot of times that is the best way to get some funding for a SOAR representative. It just sort of depends on your community at large, and maybe you could email me sort of your situation in your community, and I can really consult you with that on who to talk to.
Okay, great. Thank you. The next question could go out to both of you. What advice would you give to a clinic that is interested in beginning collaboration with the VA?
And I'll go first with that one. One of the things that I think we did right at the beginning is there was an initial conversation between our executive director and the medical director and director at the VA. And at that level, that talk can happen. So I would start pretty high as far as who's going to start that conversation to get that collaboration going. It's like the doctor to doctor, they always listen to each other thing. So I would go at that level, and also then working within, if you have a homeless coalition that you're both going to the clinic and the VA folks. The other one I would recommend is if you have a local continuum of care, which is funded through HUD, that would be another group that may be able to help you with resources and how to do that.
And I was going to just add, just the case managers, if you do have case managers in your clinic or some type of social worker that can actually go outside, if you do have outreach, that can go with the individual to the VA clinic and really meet the staff on that end. But also if you just initiate to go over there and meet, especially the homeless department would be great, and just introduce and say, hey, next time you have a client at this shelter or in the respite program, make sure you call me. But just really to initiate that at the VA. I wouldn't wait for them to contact you, but just really to go there and really pursue it.
Great, thank you. Our next question probably again could go to both of you. If a psychiatrically impaired homeless person comes to your program who identifies him or herself as a vet, Do you have a clear sense as to how to get them longitudinal, high-quality care at the VA system? What resources do you think could be made available so this is something available to more HCHs?
Bethany, you want to go first?
Yeah, sure. What we do, and again, you know, Boise is about 500,000 people, but it's still a small town, and so, you know, having relations that you can pick up the phone to call someone, so, you know, really working to know who to call at the VA when you've got a patient that you really wanted to get connected in, and I think it's much more the personal touch that will do that and help them get in there. And then, like with us, when the VA comes to us to see the patients, it's a neutral ground for some of the patients who do have some paranoia around the VA and going to the VA. So I think it's just face-to-face and personally talking back and forth and creating those relationships between the clinic and the VA.
Yeah, I agree. And also, just, you know, with sharing that story, just showing that a lot of times that trust with especially the psychiatrically impaired may not be there, and a lot of times that doc or the staff at the HCH has to build that. And I know that our doctor could bridge the medications between, but just making sure that that the doctor does talk to the VA and make sure that when they bridge them back over, just to have a really clear plan with that. But I really think that it's important that there are resources available there at the HCH site, especially if they don't have that relationship. But I think having that relationship with the LME in your area to get them connected, and a lot of times, you know, the LCSW does that to make sure that they do get high quality care, and a lot of times the gap is that reimbursement, but trying to figure that out and saying, okay, what is best for the patient, not just, this isn't just about reimbursement. So really just challenging that in your community.
Thank you. We have another question that could go out to both of you. How is VA status confirmed in your centers? We have not been very successful in finding a single point to confirm or deny VA eligibility.
I know that at the county shelter at the center, they had a staff that could look it up, but I definitely think that's an issue. Just because sometimes it can take a long time, and if the patient is transient, you may not find them again before you find out. So I really think that having a single person is the way to go, but just making sure that the protocol is smooth, because if it takes too long, sometimes you may not have that the patient in front of you anymore. So I think really maybe even having I wouldn't say an MOA, but just a firm documented plan in place on how to get that information, because I think that is a big problem.
And for Terry Riley, again, it's the being able to pick up the phone and call the VA. So our case managers, which we have two at the Boise clinic, both being SOAR trained, they do really have the relationships just to pick up the phone to talk to the case managers over at the VA to confirm the VA status for the patient.
Okay, great. This question is for Bethany. Do you think work in the clinic has been a good learning experience for the residents and students in terms of working with an underserved population?
I've had the opportunity to talk to some of the residents and to the faculty, and they feel it's very beneficial. Some of the things that they see here, they also see out at the VA, but it gives them another opportunity in the community to not only give back, because they wanted to do that, but also to see potentially some issues that they may not see at the VA. There's not a whole lot, but sometimes they do. And this also gives them the opportunity to see what the system looks like outside of the VA, because the VA is a system in and of itself, and so this gives them the opportunity to see what it's like to work in a community setting with similar populations. So yes, they have expressed that they are very happy with what they're doing, and they really enjoy coming out here.
Great, thanks, Bethany. We have one last question. This one is for Brooksand. We've kind of touched on this topic before, but I think it's a pretty important one. How were you able to gain trust with the veterans you worked with, given high levels of paranoia and mistrust?
I think really just coming into the shelters almost daily, but doing a lot of it, I guess, motivational interviewing and making sure you're not coming into their space unless they wanted you to, but really filling it out and making sure that they feel comfortable, and just really being clear on why you're trying to help them, that they're not to, you're not there for the VA, you're not there for, any other reason but to help get care. And I think a lot of times they see you around more and know that you're there, just to really help. And also I think once they see that you follow through with things, and that you care, and you get, like, if you get the doc to come meet with them and they start to feel better, I really think they gain that trust. But a lot of times you just have to make sure, as a advocate or case manager, that you are really following through with what you say, because I think a lot of times people don't follow through and they have lost trust in most of the system. So I think just really sitting down with them and just listening and making sure that they're part of the plan, and that they explain that this is what makes them feel okay, and also that they are part of the plan even when it comes down to what they need to do, because then they're more likely to follow through. But really, I think just listening and taking time just to really show that you care for them is how to build the trust.
Great. Thank you so much, Brooksand. On that note, we're going to conclude our Q&A session. I want to thank everyone for submitting some really great questions. I want to highlight a few resources that may be of interest to you. First, we recently published a literature review on women veterans experiencing homelessness. It's entitled Health and Homelessness Among Women Veterans. You can find that by following the link to our website. Also, we have another publication, Homeless Veterans and Healthcare, a resource guide for providers. You can also access this publication on our website. Please also be on the lookout for a final report on the findings of our veterans study, which should be available later this spring. From that, we'll be producing a quick guide on promising practices for establishing relationships with local VA medical centers. These publications will all be posted to our website upon completion. On that note, I'd like to thank you again for joining this webinar produced by the National Healthcare for the Homeless Council. This webinar will be archived on our website at www.nhchc.org within 72 hours. A link of the archived webinar will be emailed once it is posted to our website. And any questions that presenters were unable to respond to will be addressed by email if possible. At the close of this webinar, you will receive a survey to evaluate this production. Please complete it so that we are able to improve your webinar experience. Also, please visit our website for a listing of upcoming council webinars and other educational products. Thank you so much for joining us, and this meeting will now be closed.